This is what totally drives the treatment decisions. And that's why having that pathology report when the nurse is educating the patient is so important, because you can say, well, you have this kind of breast cancer, and this kind of breast cancer is generally treated this way.
You're listening to the ONS podcast, where ONS Voices Talk Cancer, a resource from the Oncology Nursing Society. Through conversations with subject matter experts, we examine the important issues in oncology nursing, from new treatments to patient-centered research to advancements in clinical practice. Join us as we hear from nurses in all facets of oncology care, from bench to bedside and everywhere in between. Hello, and welcome to the ONS podcast. I'm your host, Jaime Weimer, Manager of Oncology Nursing Practice at ONS. And today we're talking with Suzanne Mahon, Professor Emeritus in the Division of Hematology and Oncology at St. Louis University in Missouri, about breast cancer treatment considerations for oncology nurses. As a reminder, you can earn free NCPD contact hours after listening to this episode and completing the evaluation we've linked in the episode notes. Welcome back. Thanks again for joining us today, Suzanne.
Oh, it's great to be back. And this is such a huge topic, and it's a great opportunity to kind of break it down to make it more usable for the oncology nurses.
Absolutely. So you joined us for the first two episodes of this breast cancer series, and we've already touched on screening, detection disparities, and also diagnostic considerations. So today we're going to move on to treatment considerations. So to start out our discussion today, can you outline the most common treatment modalities that we typically see in breast cancer care?
There's really not a one-size-fits-all in terms of breast cancer treatment, but when I speak with patients, a lot of times I'm seeing them right when they're newly diagnosed and for genetic testing. And they also have so many questions about treatment at that point. And I think it's important for people to realize that there are kind of two broad categories of treatment. And sometimes I think this is a good way to explain it to patients, that there's going to be some local treatment of the breast. So we're going to take care of that actual breast cancer where it's located. And then some kind of probably systemic therapy in many, if not most cases. And that could be to treat disease that might be elsewhere in the body or to prevent a second breast cancer or a recurrence. And so, local treatment is typically going to consider some kind of surgery with or without radiation, depending on the surgery and the extent of the breast cancer. All women are going to have, and today when you use the word women, individuals assigned female at birth, they have the vast majority of individuals being treated for breast cancer. But for individuals assigned male at birth, there's not near as much research, but generally their treatment is very similar. So that's something to kind of keep in the back of your mind. But individuals are going to have some kind of evaluation of the axilla. Everybody's going to have that. And that's kind of part of the local treatment evaluation as well. And then systemic therapy can include all sorts of things. It can include some kind of hormone blocking agent, monoclonal antibodies like trastuzumab, chemotherapy, PARP inhibitors, CDK4/6 inhibitors. There are all sorts of systemic therapy. And this is kind of, as I said, a big change in the past. It used to be if you had breast cancer, you had a mastectomy, and then you got the same three kinds of chemotherapy and probably radiation, and everyone kind of got the same thing. And now it is totally based on the pathology in terms of hormone receptors, whether or not it's HER2 amplified, and the size of the lesion, and is it contained in the breast? Is there metastasis? Those are big changes from the past. And the people really, they do have choices. And I think it's important for individuals to realize that during that diagnostic period, that's kind of also when you kind of gather all that information and you try to make the best decision possible about what's going to be the next treatment.
Well, and you mentioned briefly now, and I know we talked at the previous episode when we were talking about diagnostic considerations, there are those various subtypes of breast cancer. There's the hormone receptor positive, HER2 negative or luminal A. There's hormone receptor positive, HER2 positive or luminal B, and then hormone receptor negative, HER2 negative, or commonly known triple negative. So what exactly about those various subtypes, what does that mean for their treatment options?
This is what totally drives the treatment decisions. And that's why having that pathology report when the nurse is educating the patient is so important, because you can say, well, you have this kind of breast cancer, and this kind of breast cancer is generally treated this way. Because in the public's eye, a lot of times all breast cancer is the same, and it's not. That pathology report is going to provide a lot of information, not only about treatment, but probably some really important prognostic information as well. So if you look at the most common type of breast cancer that we're going to see, probably 65, 70% of it is going to be hormone receptor positive. So it's going to be estrogen receptor and progesterone receptor positive, and it's going to be HER2 negative. So it's not HER2 amplified. The overall survival rate can be very good with this, but what you need to look at in terms of treatment when you look at this, one of the key things is that her hormone receptor positive. Okay. So that tells us that this woman is going to need some kind of hormone blocking therapy, is going to be really the cornerstone of their treatment. In most cases, they're going to have some kind of surgery, and then with or without radiation, and then they are going to have some kind of hormonal blocking therapy. This would include things like tamoxifen or aromatase inhibitors. And the decision of which to use is largely based on menopausal status. We're also seeing now the CDK4/6 inhibitors are being used more and more in this group. It used to just be for people with metastatic and more advanced disease, and now we're seeing that they probably have some benefit in some high risk, even earlier disease. And for individuals that have involvement of the lymph nodes or larger tumors, we would also be adding chemotherapy to that. For individuals who are HER2 positive, they are going to need something that's going to block that HER2. So they're going to need a trastuzumab kind of containing regimen. So typically they're going to have surgery with or without radiation in some order, and then they're going to have some chemotherapy. And then probably even after the chemotherapy with the trastuzumab, at the completion of that, they'll probably have that HER2 targeted therapy for probably about a year. And that is really the backbone of that disease. I can remember when trastuzumab first became available. And, for years we wondered, well, why do some women with the exact same kind of stage of breast cancer do well and some do poorly? And the ones that were doing poorly were individuals who were HER2 positive or amplified, and we weren't giving them the drug to treat that. And so having those drugs that treat that has become the backbone of that therapy. For individuals who are triple negative, if they are not hormone receptor positive, they are not HER2 amplified, giving them hormone blocking therapy or trastuzumab is not going to be effective because it's not going to treat the cancer. They are going to get chemotherapy. A portion of those individuals are going to have BRCA1 and 2 and other germline pathogenic variants that might be targeted by a PARP inhibitor. So that could be a part of their therapy. And individuals who are HER2 positive and hormone receptor positive, so kind of the triple positive, so to say, they're the smallest subset of breast cancer patients. And that once again, their outcome has improved because we now can give them not only the hormone blocking therapies, but we can give them trastuzumab agents, and they will also have chemotherapy. And this is very confusing for patients because they're like, well, my friend at church had this, and why am I getting this? And why are they getting something different? And that is because of the pathology report. So taking that time to explain that with the pathology, I think is really important. Another big source of question that comes up with treatment is, why do some women get chemotherapy and then have surgery? And why do others have surgery and followed by chemotherapy? Initially, the reason we would offer chemotherapy or systemic therapy prior to surgery was to help take a large tumor and shrink it down to make it operable. Or a lot of women who desired breast conserving therapy and had kind of a larger tumor, to shrink it down so that becomes easier to treat. But the other thing that happens is that if they're receiving that therapy in the neoadjuvant setting before surgery, if they have kind of a mass that's palpable or they have an axillary node that's palpable, if you give them 2 or 3 treatments, they will actually see clinically some reduction in that. And so that has kind of, first of all, it helps us to be sure that we're probably giving the best therapy, but also it's reassuring to that individual that all this therapy they're taking and that the side effects are probably worth it. For individuals with triple negative breast cancer and HER2 positive breast cancer that's a little larger or has lymph nodes, a lot of times that neoadjuvant therapy approach is a good thing for individuals. But once again, that becomes a question for patients. Well, why am I getting it first and my friend didn't? And that's because of that pathology.
The one thing I'm struck by, because I won't claim these are the oldest ones, but certainly in my career of oncology that started in the early 2000s, hormone receptors, ER and PR, HER2, these are biomarkers. And I don't know that we called it by that term when they first came out, at least not in my worldview. Like, that wasn't really a term we knew, but now it's certainly a different age in terms of biomarker directed therapy and knowing so much more about genomics. So I think it is important for nurses to understand that we don't maybe call them or think of them as this, but the receptors, the HER2 positive, HER2 negative, those are biomarkers that help inform and drive therapy decisions. And so connecting that term with what we know now to be obviously very prominent in terms of other biomarker directed therapies, targeted therapies, this is an example of that. So I just think it's important to make that connection. Since these have been around a lot longer and maybe we weren't using that terminology at the time, that is what we're dealing with here. And so it's important for patients to get that same education of, like, we're using the information about your specific cancer to make decisions about what treatment is best for you.
And it's hard for patients to understand that. And so I always say, go back to the pathology report. We see this in your tumor, and this is how we treat that.
So how can nurses guide patients in making sort of the best, most informed decision about their treatment options, helping them to understand kind of what the options are?
I think, first of all, it's important for people to understand the importance of making an informed decision. So many times, patients that are newly diagnosed, and I may be seeing them the next day because we're trying to get that genetic testing rolling, because that's also going to inform treatment. They're like, well, I don't want to wait for those 2.5 weeks for the results. They'll say, I just want to have surgery right away. And it's really important for them to understand that getting all of that information before they make a decision is really important. The pathology report gives us information, but there are other things such as genetic testing and additional imaging that are going to inform that decision, and that it's okay. Their prognosis is not going to change if they take 2 or 3 weeks at the time of diagnosis to make that right decision. And I think there's like this panic and urgency, and we kind of need to assure people that this is okay. I think it's also really important that if a good number of individuals diagnosed with breast cancer are going to have germline genetic testing, and that is very stressful, first of all, because of if they kind of think they know what kind of surgery they want, and that decision, if they want, say, breast conserving surgery, and then they come back with a germline pathogenic variant, and we recommend bilateral mastectomies, that's kind of not where they wanted to be. And that can be very difficult. And, the whole piece of the germline testing, if an individual has sisters and daughters and whatnot. So now it's not just even about them, it's about the rest of the family. So they need a lot of support during that. I think it's really important to explain to people that there's going to be local treatment. And that's where probably individuals have more choice in terms of perhaps what kind of surgery, and that they're going to have probably some kind of systemic therapy in many cases as well, and what the difference is, and that, this is going to kind of go on for a little while. Patients are also going to have multiple consultations. They're going to be seeing many people. And I think this is a place where nurse navigators make a huge difference in the outcome for patients, because they're kind of the person coordinating all of that. And you should not underestimate how important that is. So, typically at the time of diagnosis, they're going to see surgery, they're going to see radiation oncology, they're going to see plastics, medical oncology, perhaps someone about bra fitting prosthetics. That's a whole host of appointments in genetics. So, they're going to try to get all these appointments in a relatively short period of time. And I work in Missouri. It's a big state. I have patients driving a couple 100 miles sometimes for therapy. You not only have the stress of all the appointments, but the stress of taking off time and travel and whatnot, and being really mindful of all that. And I also think we really need to guide patients to reliable sources of information. And once again, I think this is a place where having a nurse navigator who's going to coordinate, making sure all those appointments get done, and, guiding them. I work with one navigator because I work with so many different practices, and she would write on the sheet, you're going to see this medical oncologist. This is the person that will give you the hormone blocking pills, surgeon. And she would write out in very general terms why you're seeing this person, and she put their phone number on there and their name. And, you may say, oh, that's no big deal. But for a patient to have all that information in one place that they can kind of review, that's a huge, big deal.
I think it'd be helpful to maybe take each potential modality at a time. So let's talk a little bit about surgery in more depth. What are some of the key points that nurses should highlight when we're discussing the surgical consultation with patients? What are their different options? How can we help kind of guide them through that decision making?
When they see the breast surgeon, all individuals are going to have some kind of maxillary evaluation. Now, hopefully it's going to be a sentinel lymph node. So they're going to, at the time of surgery, put a tracer and, they're going to take out maybe 1, 2, 3 lymph nodes. And hopefully, there is not a lot of disease there. And if that's the case, they're kind of done with that. So the sentinel lymph node evaluation, it's really more to stage and provide that information, but it kind of sets the stage a lot of times for the other treatments selections. And I think people need to realize that this is important. This is a very important procedure. Years ago, you and I have both done this for a long time. We would take out routinely 15, 20 lymph nodes in every patient. And so we saw a lot of lymphedema. You can still have lymphedema with a sentinel lymph node, but it's a lot less. And so I think that it's important to kind of start that education right there. I think women do have loss of sensation, even with breast conserving therapy, and they need to be prepared for that. If they're going to have a limited surgery, so if they're going to have some kind of breast conserving surgery, which is really when we kind of take the cancer out and some surrounding tissue that's normal, and that's going to probably be followed by radiation, what we call whole breast radiation, and a boost to that tumor bed. And I think this is a big source of confusion for patients. And this is a place, once again, where nurses can make a big difference. Years ago, when women had a breast mass, they went to the OR and it was biopsied, they did frozen section. And if it was positive, they had a mastectomy. So women would wake up and they'd be like feeling their chest because they're like, what happened here? And that is not great care. It doesn't give that woman any autonomy, but it was the best that could be done at that point. Now, with the diagnostic where we can, do a needle biopsy, they can kind of stop and take a time out, and we can clinically stage that. So if the woman has a tumor that's not very large and she has a decent sized breast and the location, she doesn't have multiple foci of tumor, she may be a very good candidate for this breast conserving surgery where you're only going to remove the mass and that rim of tissue. They need to understand that if we say that you're a candidate for that kind of surgery, the overall survival is the same as someone who has a mastectomy. And I think that's really hard for people to wrap their head around. Now, if they do that breast conserving surgery, they're almost always are going to be followed with breast irradiation. That really is a choice. And so my point is that women can be very overwhelmed when they have that choice because they're like, well, what should I do? And what the response is that, a lot of it is personal. How do you feel about that? With the lumpectomy, there's probably going to be some breast distortion down the line. The recovery is much quicker. I mean, it's really same day surgery in most cases. They can go back to work fairly, within a day or two. So the recovery is quicker, but then they're going to have probably 4 to 6 weeks of radiation following that. In women who are, being educated about a mastectomy, that can be done with or without reconstruction, and they're going to need to understand what that recovery looks like, which is quite variable depending on whether they have a mastectomy, whether they have reconstruction with an implant, or whether they do reconstruction with some kind of tissue flap. So that can be very different. So I think trying to explain to individuals or have them ask, what's my recovery going to look like with this? And what's my recovery going to look like with that? With mastectomy patients, if they're doing a unilateral mastectomy, a lot of times, especially as women age, there's going to be some ptosis or kind of drooping of the breast. And are they going to need to reconstruction on one side? Are they going to need a little lift or something on the other side to kind of, achieve symmetry? And they just need to realize that, that's more surgery. And are they going to need radiation? Sometimes women having a mastectomy might need radiation. So lots and lots of questions. And I think for women, the overwhelming thing is often that choice, that they are kind of picking it. And, there's some women that don't have choice, people that are not a candidate for breast conserving surgery, or people that have multiple foci of disease, or individuals who have a very large tumor in a small breast. Now, sometimes with neoadjuvant therapy, you can shrink that enough to make that possible, but there are some individuals where they're just never going to be satisfied cosmetically with that.
I really appreciate what you said. And again, this is experience I had recently, in those situations where it is a choice. And we do know that the evidence shows that outcomes are equivalent in terms of survival. Like there's no statistical benefit that we know of at this point with the data we have. That is almost makes it harder, I think, for many patients when they don't get a clear direction or they don't get a clear recommendation, because there is that equivalency. And also, as you mentioned, there's just lots of different variables that come with either option. And so I know that it can make it even harder to make a choice when you are given one. So I really appreciate you kind of talking through all the considerations that we as nurses should be aware of and kind of bringing those the attention of our patients so that they can factor that into their decision making. It is very complex. I'm sure there are some patients that just given sort of the concern and the worry, obviously, of having cancer, they might just immediately gravitate towards the most extreme mastectomy, just get rid of it. But I do think it's important we as nurses are able to at least make sure they are fully informed of what that means and what comes with that. And I think you did a great job of explaining some of those things. So along those lines, just kind of wrapping up the surgery piece, what is our role as nurses in preparing our patients for whichever surgical approach that they choose?
Well, and a lot of this is just kind of good basic nursing care. I mean, how we anticipate that they're going to care for the surgery site and dressing. We're used to looking at that. Patients are not used to looking at that. So just good care that way. Many women will have a drain, probably 3 or 4 drains, especially if they've had reconstructive surgery and they're like little bulb suction drains, and they have to drain them a couple times a day. And once again, we're used to kind of touching drains and things like that. But many individuals, this is so incredibly overwhelming. They, first of all, also need to kind of know how to pin them into their clothing so they don't, get pulled and whatnot. But, starting that education preoperatively and then really trying to have that individual identify someone who's going to perhaps be around to help them with that, and then trying to reinforce that education in the hospital. It used to be patients stayed in the hospital long enough that, the drains were pulled, but, even following a mastectomy, most patients are going to go home in the next 24 to 48 hours. So they are definitely going to be taking care of these at home. What are signs and symptoms of infection? How soon can you shower or bathe after surgery? How soon can they start moving that arm around? And a lot of that depends on the type of surgery. That's really important to help clarify for the patient. When can they start wearing a bra again? A lot of times they're going to go home with some kind of a binder and those kinds of things. So a lot of that is really just good post-op nursing surgical care.
I'm just struck now as I listen to you and just think through as in a nursing role, each of these sort of different modalities of treatment and these patients' experience as they move through these are typically distinct sort of nursing roles, right? If you're coaching a patient about their choice of surgery, you're likely working within sort of more of the surgical office space or the clinic space. If you're helping them with post-op recovery, you're clearly going to be either post-op area or an inpatient unit. And then as we move on, well, of course, we get to radiation and systemic therapy. And again, those are different sort of specialties and different even physical locations. And so it just, I think, resonates with me how important it is for us as oncology nurses to understand sort of our colleagues and where they fit into this and how we can learn from each other and just understand, what is that nurse's role and what are they teaching and how do they interact with the patient? And then where do I pick up from that? Where do I take that on? As you mentioned, navigators can sometimes help smooth over the transitions from all these different places, but even those nurses within the unique areas, just important to recognize that we are just one part of this patient's full experience. And so I really appreciate being able to kind of walk through each stage so that we can consider, is this the work that I do or is this the work that some other nurse is doing? But to this patient, we're all part of that care. So I really appreciate that. Let's move on to radiation therapy. When considering radiation therapy, how can nurses help their patients to understand kind of what are their options and what are the differences?
Well, and this is partly why seeing the radiation oncology team in that preoperative diagnostic stage, it is important because they are a big part of the team, even though they're frequently in the basement somewhere in your facility. They do lots of big things, so you can kind of start that treatment planning process. For women that really desire breast conserving therapy, they can anticipate that post-operatively at some point, they're going to have treatment to the entire breast. We typically call it whole breast radiation. And then they may have a boost. Now, in many, many probably cases, that's going to be over 5 to 6 weeks, Monday through Friday. So the treatment itself doesn't take but a couple minutes, but you have to get to the facility. And even though we streamline check-in processes and whatnot, you have to get undressed, you have to get positioned on the table. So it is a commitment and it can be disruptive. But if they're going to have breast conserving therapy, they should anticipate that they are going to have this radiation because it's going to treat any microscopic disease breast that was not removed in surgery. I think sometimes it's harder for women who choose mastectomy and then they're like, okay, but then I still might need radiation. And in that scenario where, if the cancer was a little bit larger, if it was in multiple lymph nodes, or if it was, kind of close to the chest wall, they may need radiation therapy as well. And then the third use of radiation therapy in breast cancer that we don't always think about, but where it can be hugely effective is, for individuals who have metastatic disease, it can be brain or spinal cord, or, it can sometimes be used for treatment and palliation. So there are multiple ways that we use radiation therapy, but, having that consult early in the treatment plan helps the individual one to meet the team and kind of anticipate what that might look like.
And as you already mentioned, all these appointments many times will occur upfront, trying to get them all sort of aligned and coordinated and at the right time. And so that just potentially adds to the overwhelm, but also can provide a reassurance of knowing that the whole team's kind of on the same page and aware of what the other one is doing and kind of when they'll fit into that puzzle that is their overall treatment. And so this is a distinct phase, but as you said, sometimes they'll understand and kind of know their options early on, but they won't see this team until potentially later in the treatment cycle. So I think it is important for all nurses, wherever you fit into this puzzle, to understand what happens at this radiation stage of the game. So thanks for explaining that. We've already touched on it a little bit, but now we'll go back and kind of revisit systemic therapy. In general, what are the tenets of systemic therapy when we use it in breast cancer treatment?
As we said earlier, it's going to be driven by the pathology report. If they are hormone receptor positive, then they know that they're going to get some kind of hormone blocking therapy. If they are HER2 amplified, then they know they are going to get some kind of trastuzumab, some kind of therapy that's going to block that. They can get other therapies for tumors that are larger or triple negative. We can anticipate that they're going to get chemotherapy. And a lot of those are the traditional agents that, have been around for a long time. The adriamycin, the paclitaxel, the carboplatin, the cisplatin, the Cytoxan. Those are all agents that we have had in the arsenal for a long time. For individuals who have more extensive disease, they have recurrent disease, they have disease that is large, we might be seeing them get some immunotherapy, things like Keytruda. If individuals are BRCA1 or 2, germline positive, or some of the other ones on the HHR pathway, germline pathogenic variants, they might get a PARP inhibitor. We're seeing the CD4/6 inhibitors with hormone estrogen receptor positive cancer, that has been a big change. Then we're also, the traditional endocrine hormone blocking therapy of tamoxifen and aromatase inhibitors. So many, many, many choices. If you follow and you look through the algorithms and the NCCN guidelines, which they change, they don't change weekly, but they do change, that provides you with a lot of guidance as to, well, this is, if you have this particular clinical state, then this is the recommended, and they tell you what the evidence for that is. So there are many, many therapies out there, and there's not a one size fits all. It's going to be driven by that pathology.
Well, I'm struck by, I'm sure this is not unique to breast cancer, but just listening to you explain all of that, it's so important to make sure patients understand kind of what type of therapy they're getting, and they might get all of them or at least a few of them in succession over the course of their disease. So it is so important for them to understand that it's not all chemo. It's not all going to be that. And so I know that that's certainly something that we deal with across all cancer treatment, because so many of our therapies are no longer that classic chemo. But thinking of patients with breast cancer who are maybe starting on chemo or maybe getting trastuzumab or something that is more targeted, or like you said, the CDK4/6 inhibitors or the PARP inhibitors, again, like immunotherapy, we're touching on every category of treatment that we have. It's just important for nurses to be able to translate that to patients. So if they are getting different classes of drugs, or if they're as their disease changes, if they are moving on to different modalities, like just so important to help clarify so that they can have the right expectations of how that experience will go for them, what their expected side effects will be, and just keeping clear that it's not going to be all that classic chemo that, again, history and media makes everyone think that that's what the experience of cancer is. And so important to keep that kind of mind when we're working with our patients. We touched on this a little bit also, but going back to sort of the targeted therapies, the HER2 targeted therapies, the trastuzumabs, pertuzumabs, things like that, how has that changed the survival rates for the patients that are able to get these treatments?
It has been game changing. And this is the difference between the patient that does well and has extended, if not long-term survival, and the one that doesn't. If we use that one size fits all and everyone gets the same 3 or 4 chemotherapy agents, these patients will not do well. I mean, the trastuzumab agent, it's going to attach to the HER2 protein, which is on the surface of the cell, and it's going to block the activity of the HER2. So it's targeting that, and it's going to prevent those cells from growing and dividing and doing whatever bad things they're doing. And then it further goes on because it's going to trigger an immune response that's going to destroy those cells. It's a powerful agent. And I think that this is where explaining to patients that there are things that they are all good systemic treatments, but they're not all chemotherapy. But I also think it's important for people to understand these are serious drugs. I was struck by someone I spoke to not too long ago, and they said, it's really good. I don't have to get chemotherapy. I'm just getting a pill. And that this pill was no big deal now. And she was referring to an aromatase inhibitor, but all of these oral agents, they think, well, because they're not having to go to the infusion room, which is another really big, if we can, some of these that we can take that away from them. But they don't realize that these are still very serious agents. They have side effects. And so really explaining each agent and how it works. If they understand the importance of that, especially their oral agents, we're more likely to see some better adherence.
Absolutely. And as you mentioned, hormonal therapies are common, for many patients, especially if their, tumor shows that they are hormone receptor positive. So what should nurses help teach patients about these hormonal agents, kind of the importance of them and knowing that they have to take them for quite a while? Just talk a little bit about what we need to be watching for and coaching patients for as they continue on this treatment.
The hormone blocking agents are going to be like the cornerstone of all of those treatments for anyone who has hormone receptor positive breast cancer. So they are going to take these agents. And as you said, they're probably going to take them for 5 to 10 years. It's quite the journey. A lot of times people say, oh, well, it's no big deal. You're just going to get this pill. Patients say, well, I'm not going to lose my hair. I'm not going to get sick. And they think, well, this is no big deal. And so you kind of want them to have a healthy understanding of the importance of not skipping it, because even though they're tolerating it really well, doesn't mean that it's a huge part of their treatment. And so having oncology nurses who can really help with that adherence is huge. So when we consider which kind of hormone blocking therapy they're going to get, one of the biggest factors is the menopausal status. Okay. So any woman that is definitely postmenopausal, they've either had their ovaries removed or they're 60 plus and they haven't had period for 5 years. And we can certainly do testing to be sure that they are menopausal. For those individuals, an aromatase inhibitor is probably a better choice because we know that it's likely to be a little bit more effective. But probably the oldest of the hormonal blocking agents is tamoxifen. I mean, there's now decades and decades of data. We know that it works. And so we can give this to individuals who are premenopausal. We can give this to individuals who are postmenopausal, who maybe are not tolerating an aromatase inhibitor. There are choices sometimes for our really young breast cancer patients who are taking tamoxifen. They may need a little bit more ovarian suppression, so they may get something like Lupron or something for a period of time. Tamoxifen is generally given for about 10 years, and the aromatase inhibitors, they're going to be given probably for at least 5 years, and then maybe a little longer in combination with tamoxifen. These are the cornerstone of treatment. We need people to kind of be with it for the long haul. The side effects of tamoxifen, people tolerate it, but it is not side effect free. They can experience some pretty significant hot flashes and vaginal dryness and kind of a discharge. there is a small risk of embolism and stroke, and it's not a large risk, but there's a risk for endometrial cancer. So, especially for these, I mean, all these women should be having regular gynecologic screening, but to be certain that they're getting that screening and that they're aware of symptoms of endometrial cancer, such as unexplained vaginal bleeding or spotting, that they act on that immediately. The aromatase inhibitors, you can also see hot flashes and muscle aches. And for some people, these are more bothersome, just like the tamoxifen, than others. There can be some bone loss with the aromatase inhibitors. So individuals who have a lot of osteoporosis, that's a consideration. We can see some elevated cholesterol and cardiovascular changes as well. No, the patient's not going to probably be nauseated. They're not going to lose their hair and things like that. So they think, well, this is not as big of a deal. But these are not like side effect free either. So those need to be managed.
And I think knowing that these therapies are sometimes taken for 5 or even 10 years, a lot could change in 10 years just in life and in sort of circumstance, and keeping patients aware of communicating if something changes in their life that is making it difficult, or as you mentioned, if they're having symptoms or side effects that are making it less desirable to just take this every day. Those are things that need to be communicated so that we can kind of talk them through what is the best choice for them and just support them through that. A 10-year period of therapy is a very long time. I think the longer you maybe get from diagnosis, it may feel like, as you mentioned, like, well, I'm feeling okay. Maybe I can just skip it this day or not take it, or maybe it's not that important. And so continuing to see those patients regularly, reassure them that it's the right thing to do. They need to keep taking it on schedule. Or if they're having symptoms or side effects, how can we help support them through that? Really important for those long-running therapies. So overall, how do you think nurses can help provide the best, most consistent emotional and psychological support for our patients, especially as treatment options continue to evolve, even for patients in the midst of treatment? We're learning new things and new drugs are being approved. So how can we best support our patients and their families as sort of the options on the table potentially keep changing?
And it is hard for them to grasp, especially for patients who are going to be taking, hormone blocking therapy for a long time. They do need to realize that this is kind of what we think, but we're going to continually reevaluate that. And in genetics, we always tell people they need an annual checkup. So, they may not need to come to our office, but we need to say, okay, has your family history changed? Has the interpretation of a variant changed? Or, have the recommendations for care changed? And that what patients need to realize is that when we made the initial recommendations for care, they were made after careful consideration, looking at the data, and that was the best decision you can make in the moment. Okay. But that they can change. And I think trying to kind of continually prepare patients for that is important. I think there's just a lot of other psychosocial things that we can do, though, that, really do kind of help patients. And I always say these are kind of the elephant in the room things that, somebody needs to talk to them about. I think body image is one of them. We are very cavalier. We say, well, you should just have the surgery, or you had breast reconstruction, so you should be happy with this. And that is not necessarily true. And we have individuals that choose mastectomy. They may choose a prosthetic, and there's nothing wrong with that. We're seeing some women that just choose the flat chest approach. And then we have the whole gamut of different types of reconstruction, which can go all the way from an implant, which is not immediate. We tell people it's an immediate reconstruction. They do not wake up totally reconstructed. They wake up usually, if they're doing implant reconstruction with an implant in place, and they have to come back, every week or two for expansion. And then, they're stretching that muscle. And then eventually they go back in and have the implant placed. And then after the implant settles, then they go back and have some kind of nipple reconstruction. Well, that is many, 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 many procedures. And it's a lot of time. It's a long piece of the journey. And you should not just assume, oh, well, they've had reconstruction, that their body image is okay, or they had a mastectomy. They must certainly be having body image problems. I just think that we just need to kind of do that. And I think sometimes it's really important to kind of ask that, because who else would be asking that? The oncologist probably isn't going to ask that question. So that becomes, I think, a really important nursing kind of issue. And I think sometimes it's kind of like, really good to kind of start with something really general, like, how's your bra fitting? Not like nothing big, but, if they say, well, I'm not happy with the disparity, or I'm not, trying to find a resource. A lot of times for these women, sending them to someone that can actually fit a bra post-operatively, either immediately post-op or a decade or two post-op is important because getting that right bra fit can take care of a lot of the things that, sometimes when the woman looks at herself in the mirror and she's like, I'm just not like happy with that. So I think starting something really general, say, a lot of times women, when they kind of get to this point, may have trouble with their bra fitting correctly. Is that an issue for you? So kind of just gently open that door for them. And I think that a lot of times just gets ignored. And I think a lot of women kind of are unhappy with that. And they also feel kind of guilty. They're like, well, I've had this great treatment. I shouldn't complain that I have breast disparity. Well, that may be a consequence of it, but maybe there's something we can do to make that better for them and giving them some guidance on where to go get that help. The hot flashes are a big deal. It is trouble sleeping. Then you don't wake up the next morning. You're crabby. It becomes very, very cyclical. And that's a reason that people will not take these medications. And so really the biggest evidence-based treatment is venlafaxine or Effexor. And it's kind of like an antidepressant, low dose. And people need to take it. They have to take it probably for 4 to 6 weeks before they even begin to know if it's going to work. So it's not like, well, I took one dose and it didn't work. And it's probably not going to completely take care of them. Maybe they'd sleep a little better at night. Maybe they'll wake up and, be able to manage it a little better. But I think, we need to address this. I was talking to someone about a year ago and she said, well, about hot flashes. And she said, well, I'm going to wait and see how much worse it gets. And I'm kind of like, why would we be waiting when, I guess we don't want to keep adding medications, but this is a case where that can have some big quality of life. If you're really crabby and things, those are some kind of big problems. I think we really need to talk to people about the importance of exercise, not only, arm exercises, but just overall exercise and getting out, because that can help kind of alleviate and prevent some mood problems. And, if it can prevent some of the side effects of some of these agents we're giving. I think you need to be mindful that if someone has had germline testing and they've tested positive, they are not only worried about themselves and they are worried about the rest of their family. That is a big deal. And even though, I'll hear mothers say, oh, I feel so guilty. Now my daughter has this. Now, I've never heard a daughter come and say, gosh, I wish my mom hadn't had me because of this. There's a lot of feelings and emotion that goes on with that. And realize that those individuals also are probably going to have fairly complicated management that goes over and above their breast cancer. They may need to have their ovaries removed. They may need pancreatic screening. Maybe they need to see the dermatologist more often. So, making sure that all of that gets taken care of. As you said, treatment changes. And, for those with metastatic or more advanced disease, they're probably going to need additional biomarker testing. And they may need it more than once because of the changes in their tumor and, kind of helping them to understand that we're doing this test because hopefully that will identify a target, so we can offer you something else. I think you need to ask the hard sexuality questions, And once again, that's kind of like an elephant in the room and patients probably not going to bring it up in most cases. I think you need to say, especially for women on tamoxifen, how much of a problem is that vaginal dryness? And there are over-the-counter moistures and lubricants. And can we help you find a gynecologist who's going to be sensitive to this, who likes to take care of our breast cancer patients and help them with this because they can't probably take systemic estrogen. Maybe they would benefit from some pelvic floor exercises and therapy. So to really ask people about that, are you experiencing a lot of vaginal dryness? Is this a problem for you? And kind of open that door once again. Or, say a lot of women tell us after they've been on tamoxifen for a while, they have problems with vaginal dryness or premature menopause. That's another group that sometimes, but it's across the board. But, kind of really just kind of saying, well, a lot of times we hear this from other women. How about you? So you kind of normalizing it. You're saying it's okay, one, to talk about it, but two, you're not alone. This goes on with a lot of other people. And I think just to really ask them how they're doing, not just, when they walk in and say, well, how's it going? And they say, fine, but really ask them how they're doing. We know that this can be life-changing for you. And we know this can be very disruptive. And give them really permission to talk to a support person, such as a psychologist or a chaplain or something, to not only you talk to them, but give them that permission that they can talk to someone else.
I couldn't agree more. I think it is, as you mentioned, the complexity of the needs that patients might have and over the duration of how long they are being actively treated for their breast cancer. There's an opportunity for unlimited number of concerns or issues or things to address and to help patients move through. And so knowing that we as nurses can sometimes be the catalyst for getting patients aligned and referred to a specialty service or rehab or whatever it might be that helps, support them. We as nurses can't do it all, but we can serve as sort of the catalyst again to kind of get those things in motion when we have those conversations with patients. And I do really appreciate and agree with the concept of normalizing and presenting questions in a way that doesn't make them feel like they're complaining, stating things as though other people have this. Is this something that you have? And so I think that does gently allow them to respond and then opens that door for continued conversation. So all great information, great recommendations, and I think applicable to any disease site, not just breast cancer, but certainly worth focusing on this population right now. Well, Suzanne, another great conversation loaded with wonderful information that I hope our listeners will find beneficial to their practice. As we reach the end of our episode, we'd like to always run through a series of quick fire questions. So to start that off, how can healthcare professionals evaluate their hidden or implicit bias about breast cancer treatment?
I think this is really important for everybody to think about. Even if I have an opinion about how I might personally manage breast cancer if I were diagnosed, I should not be sharing that with patients. There is a best decision for each patient. A lot of times if patients are newly diagnosed, they'll say, well, I'm seeing the surgeon, the plastic surgeon. And I'll say, well, did you go by the breast, the center where they sell prosthetics and bras at the same time? So when you're picking between reconstruction and prosthetics and whatnot, do you have enough information to make that decision? And that's because you want people to have all of those choices out in front before they do it. But, when patients say to me, well, what would you do? My situation and my choices are going to be different. There's a right choice for each person. And our job is to get them all of those choices. A lot of times the plastic surgeons say, well, they don't need to see the breast prosthetic center. I'm like, well, they do because they know what they're picking from then. And then they know that no, prosthetics would definitely not be for me, or, oh, maybe that is for me. So there is a right choice for each person. And when the patient says to you, well, if you were in my shoes, what would you do? You don't answer that question because what you would do is based on many, many things, and it might not be the right choice for them.
What are some common misconceptions about breast cancer treatment?
I think one of the biggest ones is that it's okay to take a couple weeks in that post-diagnostic pre-treatment phase to get all of the information, to see all of the specialists, get the genetic testing results, and then say, I've considered all of this, I've weighed all this, and now I think this is the right decision. I think it's also during this time really important to have someone who's kind of traveling with them to all of these appointments, ideally the same person who can hear all of this at the same time and be that second set of ears. And I think also for patients to realize that the nurse navigator may be their new best friend, who's kind of coordinating all of that. And I think that's important for people to realize.
What's something about this topic that's not often discussed, but you wish people knew more about?
As we discussed it, this is a journey. It's going to probably take, in many cases, years for individuals to get through it. I think people think, oh, well, I'm going to have surgery and then I'm going to be done. Or they might say, well, I'm going to have 12 weeks of chemotherapy, but that's, maybe before or after surgery, and then reconstruction. And are they going to need radiation therapy? And are they going to need long-term hormone blocking therapy or a year of trastuzumab? That this is not going to be over in a very short period of time, that it's a journey. Their needs are going to change over that time, that we need to support people not only just right in the beginning when they're diagnosed and there's a lot of anxiety floating around, but the importance of that support over the long term is very important.
What additional training or education do oncology nurses need to stay current on this topic?
The treatment is always changing. It's complicated. So first of all, kind of following those NCCN guidelines. Many institutions have a breast cancer tumor conference or tumor board where they discuss each case. And that's great. This is multidisciplinary. You're going to see the surgery and radiation and genetics and plastics and med onc, and all of those people are together in a room discussing it. And I think if you can attend those, so much you can learn about that multidisciplinary approach, why this is recommended over that. So I think that's a great way to learn a lot and gain a lot of appreciation if you're able to do that. I think you need to learn how to follow those NCCN algorithms and know how to do that, knowing how to read that pathology report and the gene expression reports that like an Oncotype or MammaPrint, so you understand how that's guiding treatment. Understanding how to read a germline and somatic tumor testing reports. there's a lot of information in there that's guiding treatment. And so if you understand that, you're going to be better able to educate the patient.
And what are some additional resources for patients or other healthcare providers who want to learn more?
Well, I always say stay away from Dr. Google. That's my first tip of the day because, Dr. Google is not always right. And that's the first thing that patients are going to want to do. They're going to go online and look. And there's so much inflammatory information that the internet is not a peer-reviewed journal. And so telling patients that we don't want them doing that. But then if they're going to do it, sending them to places where they're going to get reliable information and say, you need to stick to these 2 or 3 sites. I like the American Cancer Society. The NCCN has many resources for patients that I think you have to be a little bit more sophisticated for those, but they're there. For the professionals, we have the Breast Cancer Learning Library at ONS. The Precision Genomics Learning Library has so much information about reading these reports and things like that. And I think you should really be comfortable using the ONS biomarker database because you can look up, okay, we're giving this targeted therapy, and you can learn more about that targeted therapy, why that's being selected. And then there's links in there that take you to reputable patient education sheets that you can print out for patients. And so I think that's a great resource that people need to use more and more and more in the breast cancer space.
Well, Suzanne, thank you again. Another wonderful, informative conversation. I really appreciate your time and sharing your expertise with us and all of our listeners. Do you have any final comments to share?
I think it's always important to remember that so many of our treatment advances are due to women enrolling in clinical trials. And we forget how many women have enrolled in breast cancer clinical trials. And I think we need to be really grateful for this and to these women and, really continue to educate women about the importance of clinical trials. We've had so many advances in breast cancer treatment and care because of this. And breast cancer has taught us a lot about germline testing. It was really kind of where germline testing started. And it's taught us a lot about how we can make this the best possible experience for patients and use that to prevent malignancy. And I think finally, breast cancer has taught us how important oncology nurses are. The first navigators were in breast cancer, and the same is true of, most of those nurses who focus on adherence. Most of them were started with breast cancer patients. So a lot has come because of breast cancer. And I think, it's just so important for us to realize that the outlook is good for women.
Well, Suzanne, thank you again. It's been great to have you on the podcast today.
Thank you.
Thank you for listening to the ONS podcast. Tell us about your favorite part in this episode by leaving a review wherever you download your podcast. For more resources and information about oncology nursing, visit us at ons.org and ons.org/voice. The ideas and opinions shared in this episode represent those of the guest and not necessarily ONS.